A very good morning, respected Emeritus Chairperson, sir, Vice Chancellor, sir, esteemed faculty members, colleagues, and dear residents. I welcome you all today for this CCR by Infectious Disease Department. Our department is very new, just less than 3 months old. We are holding our OPD in SRCC block first floor in CTVS OPD area, and we are admitting our patients on male and female medicine wards, 10 beds each. We have rotational posting of medicine resident doctors to help us. If you talk about the field of infectious disease in India, it is yet an emerging branch and yet very delayed one. The most of the teaching institutes are concentrated down south, and you can see here the red ones are the government institutes, the orange one are the private hospital providing DNB course, and blue one are the private university. Currently, the best institutes in the country have a dedicated ID program, and I am proud to say that among private setup, our university is only third in the whole of the India and the first one in North India striving for academic program. The existence of a strong antimicrobial stewardship program, hospital infection control program, and strict antibiotic policy is a matter of class for any institution around the globe. It shows the commitment towards providing the comprehensive care of infectious conditions which are largely manageable and curable conditions if managed properly. It also shows the seriousness of an institution to reduce antimicrobial overuse and reducing antimicrobial resistance. The utility of our department lies in as we act as a link between clinics, lab and pharmacy, help in establishing the etiological diagnosis, differentiating between infectious and non-infectious condition, correct interpretation of laboratory workup, evidence-based treatment planning and optimization, individualized treatment based on the PK/PD parameters of a patient, deciding treatment in culture-negative infections or laboratory-negative infections, empiric therapy, and management of adverse drug reaction related to antibiotic and antimicrobials. Our scope extends from the community-acquired infections, especially those who are recurrent and complicated in treatment, any nosocomial infection and surgical site infection like Hep, BAB, CRBSI, fever of unknown origin, infection in transplant cases, infection in oncologic cases, emerging and re-emerging infections like melioidosis, Nipah virus, etc., tropical infection, sexually transmitted infection, especially HIV, antimicrobial stewardship and hospital infection control, infection prevention by immunization and other methods. And since our institution has been approved by JCI and coming for the world stage, travel medicine, immigration medicine and marine medicine is going to be scope for our department. We are seeing almost 4 to 5 cases every day, which is a decent start for our department. And we are getting 5 to 6 referrals from various departments, especially critical care, oncology, hematology, medicine, nephrology, and endocrinology. We have a very good working environment with these departments. And we are member of Antimicrobial Stewardship Committee of this hospital as well as Infection Prevention and Control Committee. We are involved in the outreach activities both within the hospital as well as in the community. And we have great assets in the form of round-the-clock advanced microbiology lab under the guidance of Dr. Ved Prakash sir, HOD of microbiology, and round-the-clock infectious disease molecular lab under guidance of Dr. Pushpen Saraswat sir, with most advanced system like Vitec 2, automated RT-PCR with full robotic system, shortest turnaround time, and gene sequencing setup. We are going and planning to develop this department in various phases. Currently, we are under the phase 1. We are trying to understand the needs of this hospital, engaging in the public relations, ID references, OPD services and admission, profiling community and nosocomial infection, optimization of hospital antibiogram, and lab testing streamlining. In phase 2, we are planning expansion, where we are striving to start academic program and research undertaking, starting of specialty clinic like travel clinic, advanced HIV clinic, dedicated wards in OPD area, point of care testing laboratory, therapeutic drug monitoring for various antimicrobial agents, evidence-based policy formulation. In phase 3, we dream of establishing an advanced ID center where we strive to achieve near unexceptional etiological diagnosis of all infectious conditions, creation of isolation room, both positive and negative pressure type, establishment of advanced molecular lab with metagenomics and biosafety level category 3 and 4 labs, non-antibiotic treatment like bacteriophage therapy and other emerging techniques, and engaging in innovation and training and leadership programs. With this brief overview, I would like to call Dr. Ashish Agarwal, who is second year resident Department of General Medicine, to carry forward this case.
Thank you, sir. Good morning, respected dignitaries. Today, we are going to present our CCR of a 30-year-old male, resident of Tonk, commerce graduate, unmarried, who assists his brother in mustard oil extraction unit In a known case of bipolar disorder on regular treatment for last 12 years presented to our hospital on 28 June 2025. Our patient was apparently alright with the chief complaints of fatigue, generalized body ache, loss of appetite, undocumented weight loss for 5 weeks and low grade fever for last 3 to 4 weeks. Patient was apparently normal 5 weeks back when on the first day of illness he developed fever in the afternoon while at home. The temperature was not documented. It was associated with chills, generalized dull body pain, mild intensity, especially in the back and lower limbs. They were not associated with any joint involvement. He took medication from a medical store and got relieved. Then, on the second day of illness, fever reappeared with chills in the morning hours. He went to a local clinic, underwent blood investigations which were suggestive of leukocytosis. He was prescribed medication and he completed his treatment of 5 days. In the next 5 to 7 days, the fever subsided. However, the patient started feeling fatigued and lethargic all the time with persistent body ache, mostly on exertion, more in mid to lower back region and legs. He had reduced appetite such that he was eating half of what he was eating previously and he had to force himself to eat. He took intermittent over the counter medication but to no relief. In the next 2 to 3 weeks, he started feeling persistent and low grade fever, but few random oral temperature readings between 36.6 degrees Celsius to 37.2 degrees Celsius. He had loss of weight in the form of loosening of clothes. He underwent investigations including blood, chest x-ray and urine test, on the basis of which he was prescribed with multiple injectable and oral antibiotics for a total duration of 18 days. But he never felt completely better and was then evaluated from a rheumatological point of view. The investigations conducted outside before presentation showed a gradually declining trend in hemoglobin and a gradually increasing trend in platelets and leukocytes with a persistent neutrophilic leukocytosis. Albumin was decreasing with Ag ratio reversal and inflammatory markers including ESR and CRP were persistently elevated. The Vidal test, chest X-ray, urine routine, urine culture and blood culture were within normal limits. Serology for dengue and malaria card test, autoimmune workup including anti-nuclear antibody, RA factor, anti-CCP and HRCT thorax were all within normal limits. This is a pictorial representation of the illness showing the various antibiotics administered to the patient during illness. Patient was given oral cefixime for 5 days initially. Then on 14 June he was started with injectable ceftriaxone and tablet levofloxacin. On 23rd June, in view of persistent leukocytosis, the antibiotics were escalated to injection piperacillin tazobactam. He then presented to our hospital on 28 June 2025 with non-resolving symptoms and low-grade fever. He was further evaluated at our hospital in view of prolonged fever. The steps taken included: patient was encouraged to take his own time and juggle his memory. Relevant negative history was obtained. Only slight indications were given and no leading questions were asked at this time. He was requested not to spare even the slightest of symptoms or details. The efforts were then done to identify the probable diagnostic clues based on history, clinical examination, and relevant judicious investigations. The relevant negative history obtained: there was no history of headache, blurring of vision, altered mentation, cough, sore throat, breathing difficulty, chest pain, palpitation or edema, or diarrhea, blood in stools, nausea, vomiting, pain abdomen, burning micturition, loin or suprapubic pain, any small or large joint pain or swelling with any oral ulceration, rashes or any skin lesions. Moving on to the past history, patient was on treatment for bipolar disorder and obsessive compulsive disease with mania and depressive episodes with history of suicidal thoughts. There was no recent change in any medication and on regular follow-up to his psychiatrist with stable course of the disease. The ongoing medications included fluoxetine, lithium and fluvoxamine. There was no history of similar complaints as current ones, tuberculosis, prolonged illness or previous hospitalization. Patient is a vegetarian by diet with reduced appetite. There was no alterations in bowel and bladder habit. Sleep was not disturbed and no history of any substance abuse. Moving on to the exposure and epidemiological history, there was no history of travel outside of his town in last 3 months or outside Rajasthan in last 1 year or any direct exposure to any pet or wild animal. He never consumed raw milk. There was no history of high risk sexual behavior or any alternative medication or treatment. There was no recent vaccination after COVID-19 in 2021 and 2022. Childhood vaccination was completed. No known allergies to any agents or antibiotics. Our patient belongs to middle class household and there is no overcrowding in house. There was no similar complaints in family, friends, close relatives or colleagues at work. There was no history of TB exposure. On physical examination, our patient had a BMI of 27 kg per meter square, belonging to obesity class 1 for Indian scenario. Patient was conscious, cooperative, alert with fair general condition. At the time of examination, he was afebrile with a temperature of 37 degrees Celsius. The blood pressure was 110 by 78 mm of Hg, pulse 88 per minute regular, saturation 98% at room air. The JVP was not raised. There was no pallor, icterus, clubbing, pedal edema or significant lymphadenopathy. Rest of the head to toe examination was within normal limits. The detailed systemic examination of central nervous system, respiratory, cardiovascular and abdominal system were within normal limits. Examination of concealed or ignored areas. On examination of scalp, fundus, sinuses and external auditory meatus, dental, oral cavity, umbilicus, genital and perianal region with digital per-rectal examination, no abnormality was detected. To summarize, we have a 30-year-old male, known case of bipolar disorder on regular treatment, presented with complaint of persistent fatigue, body ache, loss of appetite, weight loss for past 5 weeks and sense of low-grade fever for past 3 to 4 weeks and probably moderate to high-grade fever for 2 days at disease onset. He had persistent neutrophilic leukocytosis and raised inflammatory markers. He received multiple courses of broad-spectrum antibiotics with no significant improvement. He had normal general physical and systemic examination and no significant exposure history. No probable diagnostic clues were identified so far. So, the patient was advised admission, but he refused. In view of the same, the relevant lab workup was planned. Since the patient was on injectable antibiotics at the time of presentation, cultures were deferred at this time. The minimal baseline investigations were sent at this point. Since the patient had no significant risk factors, comorbidities or red flags, he was asked to stop all medications including the antibiotics other than for psychiatric ailments. He was asked to chart the temperature at least 6 hourly oral temperature with same thermometer with no intake 15 minutes prior to temperature recording, as well as to think and recollect patiently and log all symptoms. He was advised to return after 48 to 72 hours of antibiotics. Now I would like to call Dr. Beena to continue the case further.
Thank you, Dr. Ashish. Good morning, respected dignitaries and my dear colleagues. Now, the patient presented to us after 3 days with the following lab investigations. The TLC was raised, it was 16.2, predominantly neutrophilic. ALT was mildly elevated, 70.4. There was AG reversal which was present, and the iron profile showed anemia, features of anemia of chronic disease. ESR and CRP were elevated. USG whole abdomen showed grade 2 moderate fatty liver. KUB structures were all normal, including prostate. Post-void residual urine was 80 cc. The rest of the study was normal. Patient presented all the temperature chartings on which the maximum temperature which was recorded was 37.3 degrees centigrade or 99.3 degree Fahrenheit and no diurnal pattern of daily peak. A repeat detailed history was taken and facts were revisited. The patient was encouraged to speak freely. He was encouraged to provide any information based on realization or recall. A detailed repeat examination was then done. He recalled that for a long time, more than 15 years, he had difficulty in micturition. He did not feel completely evacuated after voiding and has to go repeatedly. There was a sense of urgency and need of force to micturate. He never discussed this with any family member or doctor. He feels there was an increase in this symptom since the beginning of illness. He also informed that the pain was generalized. Though the pain was generalized, he particularly felt pain in the right gluteal region, which he could not localize. The pain was dull, aching and mild, yet intense than rest of the body. The pain elsewhere responded to paracetamol, but the gluteal pain still persisted. He attributed this pain to probable unnoticed trauma and did not bother much. So now, according to this discussion, does this patient have FUO? Anyone from the audience? No, sir. He had no history of nocturia. Yes. The classical FUO criteria was temperature more than 38.3 degrees centigrade or more than 100.9 degrees Fahrenheit. It was recorded on several occasions more than 3 weeks, despite 3 outpatient clinic evaluations, 1 week of intensive outpatient investigation, or 3 days of hospital-based evaluation. So according to this criteria, a patient does not fit under FUO because the temperature recordings were not more than 100.9 degrees Fahrenheit. So what do we do next? Should we further evaluate the patient or not? Anyone from the audience? The patient should further be evaluated because the patient has persistent raised inflammatory markers and leukocytosis. A repeat local examination was then done. There was no restriction of active or passive movements at the hip joint. There was no aggravation of pain in any specific posture or movement. There was no localization on deep palpation of bones. We also did several stress tests, and these tests were performed in following manner: distraction test, thigh thrust test, lateral compression test, Faber test, which was flexion, abduction and external rotation test, and Ganslin's test. These tests train the pelvic bony structure so that the pain can be reproduced and localized. There was aggravation of pain of same character and localization in right sacroiliac region when we did these maneuvers. According to the following examination, the following potentially diagnostic clues which were determined so far are possible urinary tract involvement, possible sacroiliitis and mild transaminitis, which was less than 2 times of upper normal level. Patient was encouraged to then get admitted, but he again refused for admission. The urine routine and cultures were conducted again. 3 aerobic automated BD-Bactid blood cultures were also sent. The results were as follows. Urine RE showed 23 to 25 WBCs per high power field and 14 to 16 RBC per high power field, and protein was 2+. The urine culture showed the growth of carbapenem resistant E. coli 10 to the power 5 colony forming units per ml. Blood culture showed no growth. Now I would like to call Dr. Kapil from the Department of Microbiology to discuss urine culture reports.
Thank you, Dr. Beena. Good morning, everyone. So, patient's urine samples was received in Department of Microbiology. For aerobic culture, urine sample was inoculated on 16 lactose electrolyte deficient agar plates. Calibrated loop of 1 microliter was used and sample processed semi-quantitatively. Culture media was incubated at 35 degrees centigrade to 37 degrees Celsius overnight. Culture media plates were checked and growth of lactose fermenting bacteria obtained on culture. The colony count was calculated according to CAS concept, in which 100 colonies were counted and multiplied it by 1000. Then it became more than equal to 10 to the power 5 colony forming units per ml, which was significant of bacteriuria. The identification and antimicrobial susceptibility testing done on Vitek-2 compact automated system, in which isolated colonies were emulsified in 0.45% sterile saline. The suspension was loaded with Vitek-2 ID and AST cards, and cards were inserted in Vitek-2 complex system. After about approximately 24 hours, the organism was identified as Escherichia coli, and according to antimicrobial susceptibility test reports, the isolate was only susceptible to phosphomycin. There were two tests requested by the clinician. One was combined disc diffusion test, which was positive for metallo-beta-lactamase phenotype. As we can see in this picture, the zone diameter of imipenem plus DTA was more than equal to 5 mm than in comparison of imipenem disc. And second test was synergy test, which was done by broad disc elution between Astronam and ceftazidime and avibactam, in which ceftazidime, avibactam and Astronam synergy test was positive. The final microbiological interpretation isolate was carbapenem resistant metallo-beta-lactamase producing Escherichia coli. There was significant bacteriuria. The isolate was only susceptible to phosphomycin, and ceftazidime, avibactam and Astronam synergy test was positive. Thank you. I'd like to invite Dr. Beena. सर हम मतलब इसमें जो बैक्टीरिया मेटालो बीटा लैक्टमेज प्रोड्यूस करते हैं तो सर उसके लिए ये सिग्निफिकेंट ट्रीटमेंट ऑप्शन हो सकता है अपने लिए सेफ्टाजिन yes sir yes sir yes sir so now सेफ्टाजिडिम हाइड्रोलाइज हो जाएगी सर और एस्ट्रोनाम एक्टिव होती है मेटालो बीटा लैक्टमेज के अगेंस्ट और जो एविबैक्टम होती है जो अदर मैकेनिज्म ऑफ रेजिस्टेंस जैसे सरीन कार्बापेनेज उनके अगेंस्ट एक्टिव होती है तो जब हम दोनों कॉम्बिनेशन में देते हैं तो सर वो इफेक्टिव होता है सो नाउ आई वुड लाइक टू invite Dr. Beena to continue the discussion.
So, can I make a comment? Did you consider drug fever in this patient? Like he was on 3 antipsychotic drugs. Yes, the leukocytosis was there, some inflammatory markers were there.
Yes.
But I think drug fever should be one of the important DDs in this
So, but
case,
these
right?
drugs, these antipsychotic drugs do not.
What about lithium?
Lithium
does
causes
produce
fever
PUO.
in few, but the possibilities are rare. The case scenarios which we have seen, only 10% we could have seen that lithium can also cause drug-induced
So
fever.
10% is a massive percentage, my dear lady. 10% is huge.
Sir, it was a consideration, sir, obviously, but patient was on stable disease for like more than 1 year. So suddenly this deterioration was less likely. We discussed this with our colleagues also. They said that obviously you should rule out other things. Other things, sir, the inflammatory markers were raised and leukocytosis was there, which is not usually associated with drug fever. So, what's the rheumatologic condition like say juvenile rheumatoid arthritis? Sir, joint pain was not there in this patient. So, joint pain was not there, sir. Yes, sir, it was localized to sacroiliac. Yeah, it was a differential, sir, definitely. We'll discuss this further. Sir, no. Actually, sir, the definition of fever varies according to the guidelines and according to the textbook. The idea is fever is generally considered about 38 degrees centigrade, which is 100.4 degree Fahrenheit, persisting for more than 1 hour, or any reading about 101 degree. But in this case, many people do have like less than 100.4 as a normal temperature. It also depends upon the variability within the patient himself. For example, sir, my core body temperature may be 97 degrees centigrade in most of the time. But if I am getting 99 degree, it may be fever for me. So the idea is that every person should chart their temperature and decide that what is the normal temperature for them in different season and different time.
So for exam purposes, what my student explain, what is fever?
So sir, any temperature about 100.4 degrees centigrade should be considered fever, but it will not fit the criteria of FUO, fever of unknown origin, where it is more than 100.9, that is 101 or more than that. It is confusion.
Yes, can you tell what is the low grade fever up to how much degree?
Yes, sir.
What is the moderate and what is the
yes,
fever?
So sir,
the concept will be clear to all of you.
Sir, actually, again, this definition says that low grade fever is something up to 100, that is 38 degrees centigrade. But many guidelines do not consider this as a fever, but patient do says that we have fever, and from 99.1 to 100.4 is considered low grade fever, that is up to 38 degrees centigrade. For 38 to 39 degrees centigrade, it is called as moderate fever. From 39.1 to say more than that 39.5 high grade fever कहलाता है, फिर उसके आगे और जाके हाइपरथर्मिया कहलाने लग जाता है. So Fahrenheit में it is like 100.4 तक तो हम लोग लो ग्रेड बोलते हैं, 100.14 से 102 तक हम लोग moderate temperature बोलते हैं. More than 102 to 105 it is severe, and more than 105 point something I don't exactly remember, so it is hyperthermia. But if the patient has symptoms, he is losing weight. Yes, sir. We yes, yes. Yes. You are absolutely right, sir. We'll discuss this further. Yes, definitely, sir. Yes. Yes, definitely, sir. This particular thing, we call it as inflammation of unknown origin. We do not categorize it as a fever. I will discuss this on the discussion slides also, sir.
So what do these urine reports signify? This patient has urinary tract infection and the organism obtained was E. coli, which was carbapenem resistant. The updated classification of uncomplicated and complicated urinary tract is as follows. According to old classification, uncomplicated UTI is acute cystitis in a afebrile, non-pregnant, premenopausal woman with no diabetes and no urologic abnormalities. And complicated UTI are all other UTIs. According to the new classification, which was updated on July 17, 2025, the uncomplicated UTI is an infection confined only to bladder in a afebrile woman or man. Complicated UTI is the infection beyond the bladder in a woman or men and constitutes pyelonephritis, febrile or bacteremic UTI, catheter-associated UTI and prostatitis. So in our patient, we can categorize this UTI as complicated UTI since the patient was febrile and bacteremic UTI was present. The patient was then asked to visit the hospital and get admitted. Since this is a young male patient with UTI, this prompted further imaging. The imaging of CCT KUB was thus performed, which was normal. Then we also performed a MRI of LS spine, bilateral sacroiliac and hip joint. Now I would like to call Dr. Krunal from Department of Radiology to discuss the MRI reports.
It is not bacterium. It is not bacteremic, ma'am. It came by mistake. It is not bacteremic, but systemic features are present.
Good morning, everyone. So, a young male patient presented with clinical features of a UTI. A contrast enhanced CT scan of the KUB region was performed to evaluate for any abnormalities, including obstruction, urinary calculi, hydronephrosis, or hydroureteronephrosis. The CCT KUB revealed no abnormalities in the renal system. So on the bone window, note was made of lumbosacral transition vertebra with complete bony union on the both sides. A subchondral cyst of size less than 1 mm in diameter was also noted in the inferior portion of the right sacroiliac joint, which signify the degenerative bony change, while the left sacroiliac joint appear completely normal. In view of persistent clinical features, MRI was advised for further evaluation. So before proceeding to the MRI, I would like to discuss the sacroiliac joint anatomy relevant to our case. So this is an axial CT scan image in which sacroiliac joint is divided into the upper, mid and the lower portion. Here yellow line depicts the sinual portion of the joint while the blue one depicts the ligamentous portion of the joint. And these are the corresponding CT image of our patient. So this is a T2 weighted stir coronal MRI image focused on the sacroiliac joint, which demonstrates the mild subchondral edema involving both the sacral and the iliac aspect of the right sacroiliac joint. The left side was unremarkable. Additionally, the presacral soft tissue edema was observed with minimal right sacroiliac joint effusion. The first T2 weighted stir coronal image shows the piriformis muscle belly hyperintensity and also subchondral cyst in the iliac aspect of the right sacroiliac joint. Edema is also noted in the obturator internus muscle on the axial T2 weighted stir coronal image. Both the hip joints were completely normal. So summary of our findings are, so in this patient the changes are limited to the right sacroiliac joint, showing involvement of the synovial, which is the inferiormost portion of the joint, with the intra-articular findings of mild subchondral edema and subchondral cyst with minimal joint effusion and extra-articular findings of periarticular myositis. So overall, these all findings are suggestive of infective etiology. Now I will like to call Dr. Beena for further case discussion. So no, sir, we can differentiate between that.
pyogenic bacterial infection, we would have we would have expected more of abscess formation, more florid bone destruction, which was not there. So this is more of an indolent organism.
But sir, we have to focus on the point that patient was on treatment also. So it can be partially treated bacterial infection. We talk about the atypical infection.
So how, Akansha, how sensitive is musculoskeletal ultrasound in patients like this?
So here, because we do not have a lot of collection, we would not be able to identify anything much on ultrasound. But the cross-sectional imaging would be better in this patient. However, if we have any other patient who has visible cellulitis or things around the gluteal region, if this patient had, we could have easily done an ultrasound from the back, assess the joint, the posterior portion of the joint only, and the overlying soft tissues for any aspirable collections.
And the inflammation in the muscles which was seen on the MRI, would that have been picked up in the ultrasound?
No,
it's like a much cheaper investigation.
Yes, sir. But in this case, because usually what happens in the hip is the gluteal muscles have a lot of fat. So whenever we have fat on ultrasound, it is not our friend. So we are not able to see good below the fat. These piriformis and obturator internus both are deep muscles into the pelvis. So they are quite difficult to assess on ultrasound. Thank you.
Thank you.
Thank you, Dr. Kunal. Now, this case, the diagnosis which we have till now is a complicated UTI with right-sided infective sacroiliitis with vertebral osteomyelitis. What are the possibilities of unilateral sacroiliitis? Unilateral sacroiliitis can be of many causes, the most common one being infectious cause. Staph aureus is the most common agent over here. The other organisms are UTI-related organisms, pelvic inflammatory disease, brucellosis, salmonellosis, TB, non-tubercular mycobacteria, and melioidosis. The non-infectious causes include ankylosing spondylitis, IBD-associated sacroiliitis, psoriatic, traumatic, and degenerative. And para-infectious includes reactive sacroiliitis. In this patient, infectious sacroiliitis is more probable because it is unilateral, there is edema and collection present, raised TLC count is seen, there is onset with fever, and systemic features of chronic infection are seen. The points which go against inflammatory or reactive are that there is a short history, no other joints are involved, it is non-inflammatory type, there are no associated features of IBD, psoriasis, or ankylosing spondylitis, there are no features of urethritis, no obvious trauma, and young age generally point towards reactive. The further action which was taken was a CT-guided biopsy was performed by IR department from the right sacroiliac joint targeting the edematous bone. The sample was collected in normal saline for microbiological analysis and formalin for HP processing. The microbiological workup in the following priority was done: aerobic culture, gene expert ultra, mycobacterial culture, anaerobic culture, and sample be preserved for PCR if possible, since the collection was minimal and non-aspirable. The further tests which were done were serology for brucella, which was ELISA, IgG, and IgM, and standard agglutination test, HLA B27 antigen test by flow cytometry, and no obvious cause of mild transaminitis was identified.
Fatty liver you had, you said he has grade 2 fatty liver, that is a cause of transaminitis. You don't have to invoke an infection for that.
So we consider, okay.
Most likely, sir, yes.
Most likely, yes. After the microbiological sampling, the treatment was then started. Since we had isolated organism with susceptibility pattern for UTI, the treatment of UTI was definitive. However, the organism responsible for sacroiliitis was not known yet and may be related to UTI in this case, or maybe because of more common pathogens like Staph aureus. So the treatment empiric for vertebral osteomyelitis covering the common organisms should also be given. So the definitive treatment for UTI and empiric for native vertebral osteomyelitis and septic arthritis on the same day covering CRE E. coli was injection ceftazidime avibactam 2.5 gram plus injection azithromycin 2 gram in a single infusion of NS 100 cc IV 8 hourly. And the empirical treatment for native vertebral osteomyelitis covering Staph aureus, which is the most common pathogen, was injection teicoplanin 12 mg per kg, 12 hourly for 3 doses, followed by 6 mg per kg, which was started.
Sorry, the empirical treatment you will normally start in emergencies. This
Sir, actually,
I will understand, but for osteomyelitis, whether it is the same organism or it is a gram-positive organism, that treatment could have waited.
yes, sir, we actually waited in this case. That line is missed here. We waited for 2 days. The 2 days is the ideal time for aerobic culture to grow. So it is written on there that on same day we started, definitely UTI and empiric because it could be the cause. But empiric for Staphylococcus aureus, we waited for 2 days actually here.
So one more question. This patient, the E. coli was sensitive to phosphomycin.
Yes, sir.
So why did we choose aggressive IV regime and not
Sir,
oral
I
phosphomycin?
understand, sir. That urine culture report which was showing phosphomycin, it is for the, it is a, sir, antiseptic antibiotic. It retains in the urine, it do not go into the system. When we are suspecting infection beyond the bladder, we should not give phosphomycin. Though IV phosphomycin is available, but their cutoff is different for from the phosphomycin which is reported in urine, sir.
And beyond the bladder, evidence is the sacroiliitis.
Sacroiliitis and systemic features, sir. That is also suggested.
Systemic features could be because of
Sir, so sir, we showed the slide for the complicated UTI there. Generally, in uncomplicated cystitis, sir, patients usually do not get the systemic feature. So we had to cover systemic antibiotics, sir. On complicated cystitis, ma'am, you can. Yes, we should.
The other lab workup which arrived, which was biopsy gene expert ultra, MTB was not detected. Biopsy aerobic culture showed no growth over 5 days. Biopsy mycobacterial culture is still running sterile. Biopsy anaerobic culture was negative. HLA-B27 was negative. Brucella serology ELISA, IgM positive, IgG negative, and Brucella serology SAT titers were 1:80. The HP report showed the impression which was suggestive of a subacute or a chronic infective process. So the final diagnosis which we have now is a 30-year-old male patient is diagnosed with complicated UTI, cystitis, urethritis due to CRE-MBL E. coli, likely secondary to bladder dysfunction, with subacute culture negative native vertebral osteomyelitis, with septic arthritis, that is sacroiliitis, with anemia of chronic disease in a follow-up patient of bipolar disease with obsessive compulsive disorder. So the same treatment was continued in our case, which is definitive for UTI and empiric for culture negative vertebral osteomyelitis and sacroiliitis, and to see the appropriateness of the therapy, the test of cure was performed in this case on urine sample. After this, the urine culture became sterile and urine RE showed no WBCs or RBCs. The standard is to give at least 2 weeks of IV therapy followed by 4 weeks of oral treatment covering UTI and osteomyelitis. However, at this point, 9 days post-treatment, due to logistical and financial constraints, the patient requested for discharge and wanted to be shifted to some oral medication. The patient was thus discharged on tablet minocycline 100 mg per oral twice daily and tablet rifampicin 450 mg OD, which covered both MDR E. coli and Staph aureus. Patient was asked to watch for his bipolar symptoms as rifampicin is an enzyme inducer. He was also asked to review after 2 weeks or SOS.
Rifampicin is normally reserved as an antitubercular first-line drug. So using it for other pathogenic infections is not common. Did you not have any other choice? Why did you use rifampicin?
Sir, we use rifampicin here as an antibiofilm agent, which is a common problem in bone infection and in prosthetic infection. So the best therapy for Staph aureus as an antibiofilm agent. To eradicate the infection, we need rifampicin. So that's why we add rifampicin.
Empirically, I mean, without any culture evidence of an organism or sensitivity.
So we followed this algorithm. I will discuss this later.
So this is the algorithm for management of culture negative native vertebral osteomyelitis, and this will be further discussed in the further slides. The patient on follow-up showed consistent improvement till date, that is till 5 weeks. Fatigue and pain, including the right gluteal region, has completely resolved. There is a weight gain of 2 kg and appetite returned. There was no worsening of bipolar or OCD symptoms. The lab results were as follows. Hemoglobin was normal, TLC was decreasing, and the TLC last date obtained was 6.4. Platelets were normal and ESR was in decreasing trend, and there was no AG reversal which was present. The transaminitis had also resolved. So the next plan for this patient is a urodynamic study, cystoscopy and a repeat MRI after treatment completion. Now I would like to call Dr. Yash Sir, Associate Professor of Department of Infectious Diseases for further discussion. Thank you.
I am still assistant, so. Thank you, Dr. Beena. So we choose this case because of the challenges we faced here and the learning points we achieved. Prolonged illness like that, in our case, along with erratic treatment, often leads to poor recall and recall biases and complicating the presentation and symptomatology. Chronic predisposing condition like that of our patient with chronic urinary symptoms leads to the adaptation, and patient do not even consider this as a significant problem. Since patient was suffering from his illness for very long time, exhausted finances and patients in the patient family and relatives are a problem. Reduced sensitivity of tests, like in our case, culture was coming negative because of the treatment, prior treatment, treatment of MDR organism, treatment of culture negative condition, and drug interactions. As sir said, why we should consider this patient significant. So like fever of unknown origin, there is an inflammation of unknown origin. Though our patient did not have classical FU in strict sense of definition, but he had persistently raised inflammatory markers and considerable symptoms, which was categorizing him into a condition called inflammation of unknown origin, which is parallel to FU and suggests that there is some unknown source of inflammation. These cases should also be evaluated thoroughly like an FU with a seriousness and to identify the cause of inflammation. So we definitely persuaded this case in the same way and as serious as FUO. Now the treatment for culture negative condition, the treatment of UTI was very clear that what we have to give, but culture negative condition like native vertebral osteomyelitis and sacroiliitis, the most common pathogen are Staph aureus and UTI related. Both could have been the possibility in our case, and other cases, other causes like TB and TM, we effectively ruled out by negative gene expert ultra, which is a high negative predictive value test with more than 90% of the negative predictive value. Also, the site for TB, spondylodiscitis, is not generally the sacroiliitis. It is majorly lower dorsal and upper lumbar region. Brucella, there was no exposure, and two tests negative, serology tests were negative. So we could eliminate that thing also. So we focused on the treatment for these two pathogens, and we used this excellent review regarding the management of this condition, and algorithm is suggested in this review helps us in selecting the best empiric therapy where drugs covering both Staph aureus, which is the most common cause of sacroiliitis and spine infection, and MDR, GNB like E. coli in our case. Though susceptibility of minocycline was not available with us, it is an excellent antibiotic concentrated in bone. It is a tetracycline group of antibiotic which has excellent concentration within the bone. So you can see here, first we did the same thing. We first gave the injectable antibiotics for, ideally we should have given 2 weeks, but on the request of patient after 9 days we stopped, and we shifted the patient on minocycline rifampicin covering both Staph aureus as well as E. coli.
You had a gram-negative CRE, which was, according to you, the second most likely cause of the infection.
Yes, sir.
So, and you'd already started him on avibactam and aztreonam, the combination, ceftazidime and all that. So, could you not have waited for the response to that before empirically moving
actually,
to?
Sir,
if you have one organism which could be causing both problems, bone as well as UTI, then you could have had a response to a single agent.
Sir, the problem.
And a week later, if it's not getting a response clinically, you could have thought of using.
Sir, the problem is minocycline also covers Staph aureus, and it was the only available antibiotic orally which we could have given. So there is no way I can say that.
You haven't proven Staph aureus, no? You're only suspecting it empirically, and you got a sterile culture while you have an organism at the other side. So it makes sense that one organism is causing problem at both sides.
Yeah,
why do you want to invoke a second? It may be the most common,
sir, it is the most
not proven.
It is the most likely condition. I understand that, sir. But
when you don't have any other organism, then you start
sir,
empirical
once
therapy.
we start the therapy,
Once you have an organism, then why?
Sir, we are assuming it to be the organism of that. But once we have started the therapy, sir, we have to continue it. The therapy for osteomyelitis is 6 weeks. We cannot stop in between and start for the wait for the few weeks and start again after 4 weeks. We can't do that. Yes, but that is the only option available, ma'am. So for GNB also we gave the minocycline.
So yes, you had a patient who had bacterial sacroiliitis, and so minimally symptomatic. Shouldn't he have been more symptomatic?
Sir, I think he should have been more symptomatic, but sir, he was taking the intermittent treatment, so that could have been masked his symptoms. That was we were assuming.
And the likely scenario is that the E. coli, the UTI which he had, there was a bacterial dissemination through the bloodstream.
That is the most likely scenario, sir. But once we start the treatment, we cannot hold it in between. We have to continue the treatment. That is our problem. And minocycline unfortunately covers Staph aureus also. So
why unfortunately? Fortunately.
So sir, I
The
couldn't have.
Euroflow and the assessment of urinary tract in a young male having protracted UTI, there has to be an anatomical abnormality.
Yes, sir.
And could that not have been looked for in the 9 days while he was in the hospital
Yes,
getting
sir.
his IV antibiotics?
Actually, sir, we wanted to get the cystoscopy as well as urodynamic study. While active UTI, we are not supposed to do any urological procedure. So the idea was to conclude these things together. I wanted to do the urodynamic study, but patient didn't come up for the follow-up after 3 August. So it is still pending, but we have a plan, sir. We will definitely do it. So this review itself was based on various case reports, case series from multiple studies like this one, where the most common cause of sacroiliitis was Staph aureus, and gram-negative sector it was Escherichia coli. And again, this review and case series is suggesting that when UTI is associated with sacroiliitis, it is commonly associated with the as a cause of infection. The pathogen causing UTI is actually causing the sacroiliitis also. But sir, we couldn't be sure in this case. Sorry. So take-home messages from my presentation, this presentation today is, ma'am, we don't know what is the, why it happened like that, but maybe there is a vesivo-ureteric reflex which is coming on the, only that side, right side.
If it is bilateral, you are sure. If it is not, you can't rule it out.
Yes.
Because it's unilateral, so you rule out same organism is difficult.
Okay. Sir, वो पहले हो चुका था मलेरिया के लिए कार्ड टेस्ट. It is good sensitivity, but the picture was not fitting there because the thrombocytopenia was not there. Hemoglobin never fall that much.
Yes, sir. No, sir.
So,
You're planning a repeat MRI.
yes, sir.
How long do you expect? Number one, you expect a complete resolution if it is an infective pathology, and number two, how soon after completion of
Sir,
therapy
yes.
should you do an MRI so that residual changes are not misinterpreted?
Sir, ideally you should not repeat the MRI within 3 months because from like starting of therapy till 3 months, even the regenerative changes can be look like a infective changes. So ideally we should wait for 3 months. But if patient is not improving, patient is having any kind of deterioration, and again then we can go for MRI again. Yes, sir. 6 weeks. 6 weeks. 6 weeks we'll stop. We'll see whether patient is improved or not. Inflammatory markers are settled down. Patient is improved. Appetite is improved. Then we'll follow the patient serially. After that, we'll go for the MRI after 3 months. That is the plan, sir. He can have a flare of the infection again at that time, but we. But
you know that you accepted this 450 milligram. He's an adult. Why not 600?
Sir, it is not for TB, sir. We are using it as a anti-biofilm agent. Rifampicin is good enough for 450. For his weight, it should be actually coming like 700 or 800 if we calculate.
That is
yes,
precisely my question. Why only 450?
Sir, because
I mean, if you have to hit him hard.
No, sir. That cutoff which we are saying 15 mg per kg or whatever, it is 10 mg per kg or whatever. It is for TB. It is not for Staph aureus, sir. For Staph aureus, we ate 450 milligram only. The management of the take-home messages from our CCR today is the management of prolonged fever. FU is a game of patience. Detailed history and examination is the key. No technical advancement can actually replace this very important step. Panic or pressure-driven treatment make disease more complicated. Diagnostic stewardship improve yields and reduce cost. So, diagnostic stewardship means right test in the right patient, right time in the right way. Correct interpretation of test results are important. Choosing the best possible treatment, both definitive and empiric, is of paramount importance. I like to thank you, the mentor and the management, CCR Review Committee, Department of Medicine, Department of Microbiology, Radiodiagnosis and Intervention Radiology, nursing office and staff, and the patient and family for this case and our learning. I want to conclude my presentation with a very simple statement. FUO is far more often caused by an atypical presentation of rather common disease than by a typical presentation of a rare disease.